Thank you for the opportunity to present some of our clinical trials from ACC 15. I would like to start with the trial that was conducted in China by Dr. Wu and looked at the ability for the medication enalapril to be improved with the use of folic acid. So in this study, and it's my understanding in China, that because of the high incidence of hypertension, that there is a high incidence of stroke. In the United States, there is a lower incidence of stroke and a much more predominance of myocardial infarction. But in China, to solve the problem of stroke and hypertension, I think Dr. Wu Yang did a very interesting study that looked at nearly 20,000 patients, 10,000 in a group treated with enalapril and another group with enalapril plus folic acid. And the question was to evaluate the efficacy of the folic acid supplement for primary prevention of stroke in patients with hypertension. Overall, the finding was very significant. That is, the supplementation with oral folic acid, in fact, improved the risk for stroke and lowered the stroke rate. This, again, is a landmark trial performed in China. It was terminated because of an early significant benefit. The safety board found that there was a significant improvement in the patients taking enalapril plus folic acid, that the trial was stopped when this benefit was observed. The benefit was most significant in patients who had low folate levels in their blood, and there are some patients with genotypes that in particular are sensitive. This is the CC and the CT genotypes. So in China, where there's many patients with low folic acid levels, it turns out that an important aspect of managing hypertension and lowering stroke risk is to add folic acid to the diet. In their study, there were 10,348 patients who received folic acid and enalapril and 10,354 patients who received enalapril alone. And the percent of patients who had an ischemic stroke or a combined endpoint was significantly lowered with the use of folic acid. You can see here that there was a 2.7% incidence of ischemic stroke in the folic acid plus enalapril group, and a 3.4% incidence in the enalapril alone group. This was found in ischemic stroke. There was a significant improvement, but not in hemorrhagic stroke. It was found in a combination of cardiovascular death, MI, and stroke, but not in MI alone. So in this study, which is a very important study for the world, but in particular very important for China, that oral folic acid in combination with enalapril is superior to enalapril alone in preventing stroke in patients with hypertension. This will have effects globally in many, many populations where folic acid levels are low. I think it will take some time for us to understand in populations where folic acid is not low, how much the supplementation of folic acid will, in fact, improve risk for stroke in patients with hypertension. So we feel that, again, I want to thank Professor Wu for conducting such an excellent study, and I believe this will have impact around the world in reducing stroke rate in patients with hypertension. And once you see here with the Kaplan-Meier curve, that first stroke was significantly reduced with the combination of enalapril and folic acid. What I'd like to do while we're discussing hypertension is review briefly the new guidelines for treatment of patients with hypertension with coronary artery disease. This is a scientific statement from American College of Cardiology, American Heart Association, and the American Society for Hypertension. We can summarize this treatment recommendation with a few simple concepts. First, for people over the age of 80 years old, a goal blood pressure less than 150 over 90 millimeters of mercury is appropriate to reduce risk for MI, stroke, carotid artery disease, or others. In patients that have coronary artery disease or post-acute coronary syndrome or have heart failure, a goal of less than 140/90 is an appropriate goal. In patients with coronary artery disease who have had any of the things you see here, MI, stroke, TIA, peripheral artery disease, aortic aneurysm, or carotid disease, a goal of 130/80 is a better goal. We have had previous hypertension guidelines recently suggesting that 150 is a reasonable goal for adults over the age of 65, but I believe that has changed so that age above 80 will allow us to leave patients with a systolic blood pressure of 145, 148 without being concerned about a more aggressive therapy. One of the findings here, with too aggressive therapy in the elderly, is if the blood pressure becomes too low, there are risks for syncope, for falls and injuries, so that it's not necessary to seek a goal below 140 in people over the age of 80 years old. Some of the points in the guidelines, and let's look at the next slide. The first, a blood pressure target of 140/90 is reasonable for secondary prevention of coronary vascular disease in patients with hypertension and coronary disease. Second point to be made, blood pressure targets of less than 130/80 may be appropriate in individuals with coronary disease or past MI, stroke, TIA, or other CAD risks, and a blood pressure goal of less than 150 is recommended, as we noted before, in patients over the age of 80 years. And a blood pressure target of less than 140/90 is suggested for patients between 65 and 79 years of age. This last statement settles a controversy between the European and the American guidelines, where the European guidelines made an age of 80 the point where a blood pressure of 150 would be appropriate. In the U.S. guidelines, originally age 65 was stated, but I believe now you can see here that above 80, 150 systolic would be acceptable, and between 65 and 79 years old, we should still seek a target of less than 140 millimeters of mercury systolic blood pressure. More points that were made in these guidelines: in patients with an elevated diastolic blood pressure and coronary disease with evidence of myocardial ischemia, it's important to lower blood pressure slowly. Recall that most of coronary blood flow occurs during diastole, so lowering diastolic blood pressure quickly may cause progressive ischemia, and efforts to lower blood pressure should be done more slowly in these patients. In patients with diabetes or age over 60, reducing diastolic blood pressure to 60 millimeters of mercury or below should be limited, because again, these patients may be at risk for syncope and for falls and injuries. Another point to be made here, and this is in particular patients with evidence of prior coronary disease or heart failure with reduced ejection fraction, that a beta blocker should always be used in these patients as part of the antihypertensive therapy if the patient can tolerate a beta blocker. Beta blockers should be used in patients with a history of myocardial infarction. And again, this falls back to our common use of beta blockers in patients with ischemic heart disease, regardless of whether they are hypertensive or not hypertensive. But in hypertensive patients, beta blockers should be used in a patient with a history of a myocardial infarction. ACE inhibitor or ARB should be used in patients with MI, with LV systolic dysfunction, with diabetes, or chronic renal disease. I believe here again, if one looks at the diabetes guidelines, the guidelines from the Diabetes Society suggest that an ACE or an ARB be used in patients with diabetes to provide some protection for renal function. And also in patients with chronic kidney disease, these medications should be used. This can become controversial. Many physicians are concerned that ACE inhibitors or ARBs should be used very carefully in patients with chronic kidney disease because of risk for making the chronic renal disease more severe. I believe, though, that the guidelines are correct here, that a patient with hypertension with chronic kidney disease should be treated with an ACE inhibitor or an ARB, but carefully with observation of serum creatinine and a check to be sure that renal function is being stable. Obviously, if renal function is becoming more abnormal on an ACE or an ARB, it's important then to either adjust the dose or stop the medication. Thiazide diuretics still have a role in treating hypertension. Notice here a thiazide or thiazide-like diuretic should be incorporated in antihypertensive therapy. And in acute coronary syndrome patients, a short-acting beta-selective beta blocker without sympathomimetic activity, this would be metoprolol or bisoprolol, should be initial therapy and be given orally within 24 hours of presentation if there is no contraindication for the use of a beta blocker. The guidelines also provided some interesting concerns for drugs that one should avoid. For example, if a patient has heart failure with reduced ejection fraction, it is not appropriate to use verapamil or diltiazem because both of those calcium channel blockers can lower left ventricular function. A dihydropyridine, on the other hand, can be used in patients with reduced ejection fraction. One should not use clonidine or moxonidine, both centrally acting antihypertensive medications in patients with reduced left ventricular function. And the use of hydralazine alone should not be done. Hydralazine should always be combined with a nitrate based on prior clinical trials. All right, now I'd like to move from hypertension to atrial fibrillation. And there was a very interesting study presented at the meeting which related reduced weight in obese patients to improved outcome for atrial fibrillation. This is a study that was published in 2013 in a preliminary observation in patients who were obese who lost weight over a 15-month period. And you can see here that the treatment group, the lower curve, had a significant reduction in symptom burden from atrial fibrillation compared to a control group that did not lose significant weight, and this was significant at the 0.001 level. In addition, total atrial fibrillation duration in minutes over a 1-week period was also significantly reduced in patients who had a reduced weight from a diet program. So this group asked the question whether this can be sustained over a period of 5 years. Their question was, if the weight loss was sustained, will it be of benefit continuously in rhythm control? Next. They also were concerned with weight fluctuation, that is, some weight loss and then a gain in weight and then a loss in weight again, and asked the question about weight fluctuation. So their goal here was to examine a dose-dependent effect of long-term weight loss on freedom from atrial fibrillation and the impact of weight fluctuation. They also wanted to emphasize the role of the use of a dedicated weight loss clinic. The primary outcome, atrial fibrillation, based on a questionnaire, and freedom from atrial fibrillation on a 7-day Holter monitor. And secondary outcomes were structural changes in the left ventricle and left atrium from measurements from echocardiography. And they were also interested in measuring metabolic and inflammatory profiles, although in this presentation, the metabolic information was not presented. So there were 1,400 patients. They were screened to a final cohort of 355 patients, and they were divided into patients who went through a weight loss program who lost less than 3% of weight or gained weight, patients who had 3 to 9% weight loss, and patients who had greater than 10% weight loss. And these three groups were compared. The first interesting piece of information I thought that was very useful was this set of data. On the left atrial volume by echocardiography. And you can see here that the follow-up groups at 5 years had no reduction in left atrial volume if they did not lose weight, and had a very significant reduction in left atrial volume if they had a greater than 9% weight loss. And intermediate patients had an intermediate change in left atrial volume. Equally important on the right slide is the fact that septal thickness intraventricular septal thickness measured by echocardiography showed a significant reduction in the patients who had a greater than 9% weight loss. So in this study, a weight loss of greater than 9% had significant effects on atrial fibrillation incidence and on left ventricular dimensions. Here again, the symptom burden was a reported symptom list from the patients. You'll notice here again a significant reduction in the patients who lost greater than 9% of their weight. And the sense of global well-being done by a questionnaire also showed a significant improvement compared to the other two groups in the group that had a greater than 10% weight loss. And here again, if one looks at AFib freedom without an antiarrhythmic drug or an ablation over 5 years, you will see here that the group with a weight loss of greater than or equal to 10% was significantly higher in AF freedom when compared to the other two groups. So here again, over a 5-year period, there's a significant ability to eliminate atrial fibrillation without ablation or antiarrhythmic drugs if the patient loses 10% or more of their body weight. And here we see the question about linear or unstable or weight fluctuation. And you'll notice here again that the continuous loss of weight over 5 years showed a significant freedom from atrial fibrillation. This could have been with drugs or with ablation, but 76% of patients at the end of 5 years were free of atrial fibrillation, and they may or may not have had medication or ablation. If the patients did not lose significant weight, you'll notice only 38% of the patients had freedom from atrial fibrillation, and more importantly, fluctuation of weight fell in between, so that gaining and losing weight over a 5-year period does not provide the same advantage as a continuous weight loss over the 5-year period. Sustained weight loss is associated with a dose-dependent reduction in atrial fibrillation burden and maintenance of sinus rhythm. A greater than 5% fluctuation over that time dampens the benefit conferred by the weight loss. And they also pointed out that a dedicated clinic improves patient engagement, promotes treatment adherence, and prevents weight regain and fluctuation. I think this last point is very important. Most obese patients have a very difficult time managing weight loss without some assistance, and a dedicated clinic seems to be one important solution to improving weight loss. Now, there are two other interesting atrial fibrillation studies. One compared surgical ablation of AFib during mitral valve surgery compared to just mitral valve surgery alone in patients that required mitral valve surgery for mitral regurgitation. In this group, the comparison was between patients undergoing mitral valve surgery with a surgical ablation of the atrial fibrillation compared to the same surgery without the ablation procedure. The findings suggested that AFib ablation is effective when done during the surgery at improving freedom from atrial fibrillation. There was no difference in serious outcomes, major adverse cardiac or cerebral events, and no difference between ablation techniques, that is ablation versus Mays procedure. Let's look at some of the data. Next slide. If you look at the difference in percentage of freedom from atrial fibrillation, mitral valve alone, 29%, mitral valve plus ablation, 63%. So there is a significant effect of ablating atrial fibrillation while doing mitral valve surgery. On the other hand, if you look at the group that received ablation, there was no difference if the ablation was done by pulmonary vein isolation versus a Mays procedure. Both had significant improvements in outcome, and either procedure had about the same result. If we look at serious events, you'll notice the two curves are quite similar. So in either case, there was no significant effects on long-term survival. So either procedure, that is mitral valve surgery alone or mitral valve surgery plus ablation, could be done without concern for long-term survival. However, the patients who received the ablation procedure had less atrial fibrillation over this period of observation. Okay, I'd like to finish this discussion with a comparison of atrial AFib ablation compared with amiodarone treatment for atrial fibrillation in patients with the congestive heart failure. These are patients who had an ICD device or a CRT, that is a resynchronization device, implanted and were in atrial fibrillation, and it was a test to determine whether patients could be restored to sinus rhythm using either ablation or amiodarone. The goal was to compare, again, catheter ablation with amiodarone in patients with AFib and heart failure. And again, the catheter ablation procedure left to a higher success rate than amiodarone therapy. And the ablation with preservation of sinus rhythm improved left ventricular ejection fraction, 6-minute walk test, and frequency of hospitalization over 2 years. Let's look at some of the data. Next slide. They randomized a group of patients over 18 years of age with persistent atrial fibrillation who had ICD or CRT implanted, New York Heart Association 2 or 3, heart failure, and an ejection fraction less than 40% identified within the last 6 months. And the question was whether amiodarone or catheter ablation would be superior for the treatment of persistent atrial fibrillation. The randomization was to either amiodarone or catheter ablation, and you can see here that once the randomization occurred, there was a trial period of approximately 24 months and observation at the end of the trial. The patients had ejection fraction by echo, 6-minute walk distance measured, and a Minnesota Living with Heart Failure questionnaire. This is a questionnaire of well-being with patients with heart failure. The important finding here can be seen in this graph. The amiodarone group had a significant reduction in atrial fibrillation, so the proportion of patients who, the amiodarone group had a less reduction in AFib freedom compared to the catheter ablation group. The catheter ablation group showed about a 75% freedom from atrial fibrillation, while the amiodarone group about a 38% freedom from atrial fibrillation over a 3-year period. So I think the data from this study suggests that patients with heart failure with atrial fibrillation who have devices implanted, particularly CRT and ICD devices, can undergo catheter ablation and will have successful outcome. Just for comparison purposes, one can see here that in the patients who had no recurrence of atrial fibrillation, and you look at ejection fraction, there was a significant improvement in ejection fraction of 9.6% compared to 4.2 for patients who retained atrial fibrillation. The 6-minute walk distance improved by 18 meters in the patients who had no recurrence versus 7 meters in the recurrence group. And a quality of life questionnaire showed a significant improvement. These are in negative numbers indicating improvement, which was significantly better than the group with the recurrence of atrial fibrillation. So I think, next slide, the conclusion from this study is that if a patient has persistent atrial fibrillation with heart failure, that amiodarone alone is probably not the best choice in managing these patients, but catheter ablation does reduce hospitalization and mortality in patients with heart failure compared to amiodarone. Thank you.